Good afternoon, everyone. So let me go through a few things before we start the webinar. So the chat box will be open throughout the entire webinar. So please feel free to drop in your questions in the Q&A box below, and we will collect all these questions and address them during the end of the presentation. So let's just wait for a couple of minutes, okay? Doctor, have you had your early breakfast or lunch?
I would say early breakfast, yeah. I don't eat much in the morning anyway, so, and probably have lunch with my parents after this. But yeah, hopefully we'll have a good time.
Yes. Okay, doctor, shall I begin?
Yes, let's go.
All right. Okay. Good afternoon, everyone. My name is Nolan Krishna, and I'm a Year 5 dental student, current president of PIDC Virtual Circle.
Good afternoon, everyone. My name is Jordan. I'm a third-year dental student, and I'm a member in PIDC Virtual Circle.
And we will be your moderators for today's session. So before I begin, I shall introduce Dr. Kamil Hassan. Dr. Kamil graduated with a Bachelor of Dental Surgery from the University College Cork, Ireland in 2012. He obtained his membership of the Royal Colleges of Surgeons in 2015. He then pursued his training in the field of oral and maxillofacial surgery in the National Maxillofacial Unit of Ireland. He completed his training with a Master in Research Science in Oral Surgery in 2018 and subsequently awarded the Specialist Fellowship of Faculty of Dentistry, Royal Colleges of Ireland in 2019. Dr. Kamil had served as a dental officer in the Ministry of Health from 2012 to 2013, and currently he is a clinical specialist and lecturer in the Faculty of Dentistry, University of Malaya. His surgical interest mainly focuses on the corrective jaw surgery, orthognathic surgery, 3D virtual planning, and also printing and surgical simulations, impacted teeth, management of osteonecrosis of the jaws, and minimally invasive treatments of TMJ dysfunction. Dr. Kamil, the floor is yours, or shall I say the screen is yours?
Thank you very much, Nolan. Before I share my screen, I would like to thank the members of the PIDC Virtual Circle for inviting me for today's talk, especially Ms. Manmeet, who actually approached me through Instagram and asked me to basically do something, a sharing session, as I would like to say it, for everyone who's here today. I'm very honored and very humbled to be here today. So thank you very much for joining us. My talk will be roughly about 30 to 40 minutes, and then we'll be answering some questions if there are any. And because of that, let's have lunch together while you listen to me mumbling all day long. All right, okay, so Nolan, I'm going to share my screen now, yeah? Is that okay?
All right, doctor.
Thank you. Right, okay. So, let me know if this is up. Yeah? Can everyone see the slides? I hope you can.
Yes, we can. Yeah.
Yes,
you can
doctor,
hear me
audible.
clearly, yeah? Right, okay. Again, thanks again to Nolan for the introduction, very kind introduction, and that is basically the gist of my life since graduation. But I'll tell you a bit more about myself later on. So when PIDC approached me, I had no idea what to talk about because oral and maxillofacial surgery is a very big field. And although the title says the bridge between dental and medical fields, it's not really, what would you say? It's not really focused on that. But again, if there is any questions, then I'll be happy to answer. So my name is Dr. Muhammad Kamil Hassan. I prefer to be called as Dr. Kamil Hassan. I'm an oral and maxillofacial surgeon and also dental lecturer in the Faculty of Dentistry, University of Malaya. So a bit about myself. I am actually born and probably raised in Perak. I was born in Taiping in 1988. I am the third out of 5 siblings, but unfortunately, I'm the only dentist among them. My parents are both dentists, so which probably shaped where I am today. My dad is an orthodontist in the army, retired now, but still working in private. My mom is a private dental practitioner with a public health degree. I am married to a lovely wife, my Sarah, and I have 2 sons, 7 and 4, Martin and Alfie. And as you all know by now, that I am currently working as an OMFS surgeon in the Faculty of Dentistry in Malaya. As you can see on the top right picture are my parents. It's my firstborn in the clinic. Bottom is my basically picture of my family during my graduation for the fellowship degree. And that cat is not a real cat. It's not my cat. I promised my wife that we'll have a cat after we got married. Unfortunately, my kids are allergic to cats, hence we don't have a cat. Okay, so enough about cats. Tell you a bit more about my education, how it all happened. So again, living in Perak, most of my years growing up was in a small town called Lumot in Manjung. Lumot is known for their Navy base, and over there's an army hospital, Hospital Angkatan Tentera TLDM. That's where my dad served as the head of department for the dental department. And so I went to, basic, normal daily school, SK Methodist ACS Lumot, went on to ACS Sichawan, and then after SPM, I got offered a scholarship under the JPA, and during the scholarship, I said, yeah, I want to do dentistry. Why do I want to do dentistry? Because my parents are dentists. So such a lame excuse, but I guess living up with 2 dentists in the family, it kind of shaped off where I wanted to go from there. So I went to College Marabanting. I did an international baccalaureate diploma, and eventually I ended up in a place called University College Cork in Ireland. It is south of Ireland. They say it's the sunniest part of Ireland, but unfortunately Irish weather is always raining, strong winds, and most of the time you don't see any sun. So I've never heard of University College Cork before. Through my research, I wanted to go to Dublin because I heard it's one of the best dental schools over there. But nevertheless, University College Cork was a fun place to go to. Pretty small, nice town, nice people there. Our batch only had about 30 people in there. And I made lifelong friends from Ireland, from Africa, Botswana, and everywhere else. So in 2012, when I actually graduated with a bachelor's, I came home because, with JPA and all that, so I came home and then I worked as a FIDO officer. That's how we call it, first year dental officer, rather than NDOC. And I wanted to go to work in Kinta, Perak, so that is basically Ipoh. So I was there for about 2 years and I had fun because the oral surgery department was a very nice place to work with. Again, a lot of friends I made, and I also made a friend from PIDC. His name is Dr. Thomas Moore. So that's when I actually first heard about PIDC. He was a bit senior in terms of a few months ahead of me. So he actually helped me to, go through things, and that's a kind of co-worker, colleague you want to start off your career with. And then I decided what did I want to do to specialize. My dad's an orthodontist. He works probably 4 or 5 days a week. He plays golf in the afternoon. Work-life balance is great. So I said, yeah, why not orthodontics? So I told him, Dad, Abba, I want to do ortho. And my dad said, no, there's going to be too many orthodontists by the time you finish. So I said, why not look for something else? Maybe do something that you're not comfortable with and see whether you like it or not. So I wasn't comfortable with oral surgery at all. In fact, when I graduated, I only expected 1 tooth, and I didn't do any surgical procedures at all. So, graduating with very little oral surgery skills is not something that you would expect and become an oral surgeon afterwards. So looking into the KKM system and the long waiting list to further study, I decided to approach nearly all local universities, and fortunately I ended up with UM and became a training lecturer there. So the dean at that time said, look, you graduated from Ireland, when I send you back there? I said, oh my God, Ireland again? Yeah, so I got sent back, and then this time it was Dublin, the place I actually wanted to go and train. So St. James's Hospital is the one on the upper right, and that's where I did most of my training in. And that's where I did my research degree, the MSc, and subsequently after my training, I sat for the specialist fellowship exam and failed the first time, but failure just makes you stronger, and studied for the second time, and then I passed. So yeah, good. So that's where I am. I finished in 2019, came back home and served the university. So as someone who works in the university, you're an academician. Your work does not only resolve around giving lectures, teaching, but also doing the surgical part and also doing some research. So I guess my career in teaching started quite early, even during my training years. On the upper left photo is me with some dental students from the Trinity College of Dublin. I worked there part-time as an oral surgery tutor. So we would do extraction sessions or biopsy sessions together. As you can see, I am probably the youngest in that photo. In UM, I, again, is teaching undergraduates, teaching postgraduates, giving lectures, chair-side teaching, surgical teaching, and it's all, it's not only just sitting in front of the microphone and just giving lectures. So it's actually a wonderful experience, and I enjoy it every time. Okay, as a surgeon, I treat patients as well. So I love to educate patients, discussing options with the patients, what kind of treatment that we can offer them, and how we can help them or change whatever they want to have changed. So I do from minor oral surgery, removing lesions, soft tissue on the lip, removing third molars is bread and butter of an oral surgeon, basically. Treating traumatic injuries, as in the right photos, mandibular fracture, maxillary fracture, fractures of the teeth, etc. That's actually a picture of my own tongue, which I did appendectomy. I didn't do myself, of course. I had a colleague to do it on me. And also trying out new techniques or alternatives. So in the lower right picture is a picture of a patient with a mandibular trauma. The upper one is with an arch bar, the lower are with brackets, orthognathic brackets. So it's something that I brought from training abroad to see that, we can actually do something that's less invasive to the patients and help patients have a better quality of life in terms of surgical treatments and so on. As a researcher, I guess the way that I was trained a lot in orthognathic surgery or corrective jaw surgery. And coming back to Malaysia, I was introduced to this company called 3D Gens in Bukit Jelutong near Shah Alam, and they had a 3D printer. So I said, yay, 3D printers. So we can print everything from any radiological images. So I started working with them as early as end of 2019, just before COVID. We've pioneered the first 3D printing and virtual simulation in orthognathic surgery, which is great, of course. And since then, I've been working with other companies such as Device Synthesis, which is under Johnson & Johnson's. I work with my postgraduate students, and especially with my major interest in jaw surgery, to find different techniques or ways that we can improve surgery. So that's basically my research interest. I do this video underneath is finite element analysis. So basically it's a biomechanical study by using computers itself. Right. So that's basically my life as an academician you have. But the things that I enjoy will be coming in the next slide. And if not used to surgical photos and blood, you might want to close your eyes. But this is quite interesting because these are what surgeons live for. So I love to do jaw surgery. I love to correct people's teeth, put them in the correct way that probably can't be done with orthodontics alone. Maybe because of my earlier interest in orthodontics has led me to go into this kind of path. But here's a photo basically that we are putting this patient's jaw in, we wouldn't say a correct position, but a more harmonious position that can also improve the patient's aesthetics as well. So this is actually a surgical first orthognathic surgery where we remove the jaw before the teeth are actually moved into its correct place to basically shorten the whole treatment time. So you can actually break our jaws and then put it in a new position, plate them, and then it heals nicely after a few months. Okay. In Dublin, we did a lot of this, a lot of head and neck surgery, very extensive, very demanding, and takes a lot of time. This kind of surgery takes the whole day from 8 a.m. to probably 12 midnight. And this is patient's oral cancer. So because I've seen a lot of these kind of cases, mentally, to be honest, I'm not too keen with oral cancer just because it's kind of sad in a way, but some people have to do it, so we do it anyways. When we take out cancer with surgery, you remove the tumor, you remove the cancer, you have a defect in the oral cavity, and how do you fill in that defect can be done with a lot of things. Thankfully, I mean, if you believe in God, I believe in God. They made us in a way that our bodies have extra tissues that we can use in all sorts of ways. And in this case, the mandible had to go. So we had to reset the mandible, remove the mandible. And after that, we have an extra bone in our leg called the fibula. The fibula bone itself is a bone that is situated just at your calf. And what it does is it stabilizes the knee joint and the ankle joint. So if you take something in the middle, you don't disrupt anything at all, and you can actually use that bone to reconstruct the mandible. And this is what we call as a free flap surgery. It comes with the blood vessel. The blood vessel is then connected or anastomosed to the vessels in the neck. And because of that, it does not rely on the surrounding tissues to survive, and the surgical outcome is outstanding. It really is. It's life-changing. So imagine you remove a tumor, you put another bone back in, just as if that there's no surgery was done. So when you do these kind of surgeries, and even corrective jaw surgeries, what I want to say is that you kind of move away from dentistry a lot. And you don't only treat teeth, but you treat the patient as a whole. And because of that, you have to manage the patient as a whole. So you need to have that understanding of medical knowledge and basic surgical knowledge, really. So when you treat teeth, and even as simple as teeth, you want to extract teeth, if you don't have basic knowledge in general medicine surgery, I don't think you can manage the patient holistically, right? So all patients will eventually come with a certain medical condition that if you as dentists do not really know how to manage or know when to refer, it can cause a lot of trouble. But if you do know, you have a certain knowledge in medicine and surgery, which we all have, and which we all learned during our earlier years in dentistry. And if you keep on practicing it, then you will be able to manage the patient better. And that goes a long way in terms of patient management. If you want to ask a bit more, then we can discuss this a bit more later on. So these are the surgeries that I've done and have done in the past and still doing in the present. And so one of the topics that was asked is, what was my major case as a specialist? I think all cases are considered major, but this case itself has a special place in my heart because this was actually my first corrective jaw surgery done after qualifying as a specialist. So it wasn't my patient to begin with, but it was passed on to me by a colleague. And I told the colleague, like, you know, I've assisted lots of jaw surgeries. I've never done any one of them independently. So I said, can you, you know, possibly back up for me if anything, you know, that doesn't go well? So he said, yeah, he'll be there. He said, he'll be there. And so we started off the surgery. We did the upper jaw, he didn't come. And we did the lower jaw, he didn't come. And then we finished the surgery and he didn't come at all. So it's major in the way that it was something that I had to handle myself, and if there was anything wrong, I'll be alone. But thankfully, it went well. So this girl actually came all the way from Johor Bahru just to have a surgery done in PPUM. And I follow all my patients for jaw surgery at least for 1 year. And the good news is that when we met again a year after the surgery, she has got a new job. She's smiling more, and it has basically changed her life. So my major case would be this first case that I've ever done before. But like I said, all cases that I treat, I consider it as major. I mean that I treat them all the same, with the same aim and same expectations for the results. And then it comes down to what are the surgeries that I like most, and I can't deny it. I love orthognathic surgery, corrective jaw surgery. Why do I like it so much? I don't know. I guess when I do this sort of surgery, is that it gives me satisfaction in seeing that the results are almost instantaneous. Similar as, you know, a lot of dentists nowadays are very into aesthetic dentistry, a lot of smile makeovers, orthodontics, you know, putting teeth in its correct position or the best position and all. But orthodontic surgery has a special place in my heart as well, because most of the patients that I treated came back with good, positive results, whether it's life-changing, whether it's in terms of psychological, social, or even financial, which is great. And it's great to see that these patients are doing well afterwards. The one on the upper left is actually a patient from my dad. So if you're wondering, you know, father and son working together for a case, I mean, that's the best thing that could ever happen. So my dad did the orthodontics, and then COVID came, so she was supposed to go to another government hospital. I said, look, bring her to UM and then do the surgery for her. And I'm actually glad I did it for her anyways. Upper right is the same photo, the one that I showed earlier on is the surgery that we did, and she's great as well. Lower pictures and the lower left is actually a 40-year-old lady with an asymmetric mandible. That was a corrected jaw, came all the way from Johor as well, moved multiple of times. And then the patient with cleft lip and palate, which they have facial deformities because of their previous surgeries, and the condition alone causes the maxilla to be hypoplastic. So cleft lip and palate patients, they don't stop the treatment after their lips and palate are repaired during their childhood, but it goes on until their early adulthood years, where you then have to correct the jaw, and that's basically like, you know, the final haul of the cleft lip and palate management as a whole. So basically, doing the last thing for them is to make the jaws in the correct position. So then, you know, being a surgeon is not only about doing the things that you learned, but also moving on and also being up to date with the new trends, new technologies, and foreseeing what the future have to offer. So in orthognathic surgery in other parts of the world, especially in America, 3D planning is just like, taking an alternate impression in clinic. It's like it's so basic that they do it for all their patients. But in parts of the world like Asia, where economically wise, it's not great. So treatments can be very expensive. And to do 3D planning in Asia costs a lot of money. Not many people have that money to spend. So how do we do it then? So we have a local company, again it's 3D Jets, fortunately, local trained, locally made, and very enthusiastic people that does a lot of printing in the medical and surgical field as well. So we moved on from taking casts, Facebook registrations, all that, putting them, simulating the movements on the articulator, and then making acrylic wafers to guide for the surgery. And all of these have human errors, lab errors, material errors, and all that. So why not do something that's a bit more predictable and a bit more accurate, when we have computers that are very good nowadays, computers that are with good specs. All of you play games with the computers, so you need very good graphic cards and all that. So these are the kind of computers that can actually hold the load. So we had a patient that was referred from my dad, and this patient had a bit more of a severe asymmetry of the mandible. So I decided, hey, why not we do this as our first case, and we can actually give a bit of a waiver in terms of fees. So the patient agreed. But unfortunately, virtual planning is not as easy as it looks, and not everything is perfect. So again, with this patient's virtual planning execution was not as what I anticipated it would be. So although we simulated it on the computer and looks nice, but when we transferred it to the patient, it wasn't as what we expected. So again, problems do arise, whether it's virtual planning or not. But we can always learn, and we can always be humble, and we can always know what to do next and improve. Okay, so this patient is doing well, although she's happy, but the surgeon is not happy. So when the surgeon is not happy, you can't do anything much about it. Okay, so probably be seeing her soon, see how she's doing. But being a surgeon itself is not straightforward. There are challenges, and challenges can be in all sorts of ways. And when I talk about challenges, I would like to talk about where are the challenges. And the challenge can lie in myself, in my patients, and also the environment. So I guess I'm my biggest enemy and my worst enemy, because there's a lot of self-doubt. You keep on asking yourself, are you good enough? Can you do it? Can you do the surgery? Do you have enough skills? Do you have the knowledge? And what if this go wrong? What if that go wrong? And when there's a lot of self-doubt and little confidence in myself, then it makes things a bit harder. But the only way to overcome that is to, if you think you're not good enough, then you have to think of what am I not good in and how do I improve? And when you say, can I do the surgery? So then I ask myself, have I done the surgery? If I've done it multiple times, then what is wrong this time? Or if I've never done the surgery, then I should ask who have done the surgery and who can teach me to do the surgery. And if I feel that I don't have the skills and knowledge, then I have to look for the skills and knowledge. And that is the way that I overcome this kind of challenge. But the challenge also lies in our patients. And we know that patients are not always easy patients. And in maxillofacial surgery, breaking bad news is horrible. It's hard, especially when the bad news involves cancer. It's hard because it's not only hard for the patient, it's hard for yourself. You have to be straight. You have to be honest. At the same time, you cannot say that you know how the patient feels. You don't know how the patient feels because you don't have cancer. So it's hard for you to actually be truthfully empathetic. There'll be patients who are unhealthy and you want to help them, but they are unhealthy in a lot of ways. They have a lot of medical conditions that makes them cannot go through surgery under general anesthesia or even under local anesthesia. And unhealthy patients can be because whether it's medical or psychological as well. You'll have difficult patients who have visited the Google doctors, patients who have a lot of demands, patients who are actually your family or friends, and those are, ethically you should not treat them, but when people come to you, it's hard to say no, right? So again, patients do form kind of challenge that is a bit different. And then you have challenges from the environment, which is anything that is surrounding you, whether it's finance, whether there's enough money to do the surgery, whether the hospital has enough money, or whether you need money to buy things, you need to buy loops, you need to buy headlights, or you need to buy whatever instruments you need. Yeah, that's another challenge, because if you don't have those things, then you cannot do the surgery. Then there are, again, equipments, as I mentioned before, and of course, finally, workplace politics and bureaucracy. That is something that we can never run away from. And this is just part of life and work itself that everyone will go through. So it depends on how you manage, how your relationship is with the administration, with your co-workers, your colleagues, the other departments, and so on. So it will always be a challenge. There will always somehow be a conflict of interest here and there. But again, it's just a challenge that you have to go through. You go through it fine. As a surgeon, and especially as a young surgeon, to gain patients' trust or even your colleagues' trust is hard, because I remember when I just graduated with a bachelor's and I was working as a locum in my mom's clinic. I was going to extract the patient's tooth, and then the patient's like, awak ni doktor ke? Kenapa awak muda sangat? Why am I too young? Why do I look young? Because apparently my parents, they're a bit older, and then age can be a challenge as well, where patients find it hard to trust you. So if it's guys, just grow some facial hair, make yourself a bit older. If girls, I don't know how. I guess girls need to retain their youthful look. But in gaining patients' trust, the most important thing is to be professional. Be professional in a way that, your communication skills, the way that you dress, the way that you look, the way that you comb your hair, the way that you, wear your tie or put on your gloves, all those come together. And if you don't have, or if you don't look after that part of yourself, then it's hard to achieve patients to trust you. A lot of dental clinics nowadays, you don't wear shoes inside the clinic. You take off your shoes outside, and then you come in. This is private clinics especially. So you would want to at least wear a pair of socks or indoor shoes, because you don't want the patient sitting there and you're talking to them, and then the only thing that they can look is looking at your feet, and that is something that is a bit awkward to be. All right, so professional in terms of how you present yourself. Be humble. Okay, you're not bigger than anyone else. You might be a good dentist, the best dentist, but or you might be a specialist, or you might be a specialist in training, but doesn't mean that you're better than anyone else. So be humble, always be humble. Listen to the patient, and when you're listening, be empathic. So empathic is different than empathetic. And if you want to know what is empathic, you have to know what is empathic listening. And the best place to learn about it is if you can Google empathic listening. There's a whole lot of things out there, but this is my suggestion, my tools. How did I come across empathic listening? Is that my wife and I go through this parenting course because we want to be good parents to the kids, and as human beings, you need to know, you need to listen to your kids. Things have changed nowadays, so there's a lot of styles and everything. Parents writing skills. But anyways, look into empathic listening. It will go a long way. Okay, be truthful. Don't lie to your patients. Educate your patients and be ready to learn from the patient. The patient might know something a bit more than you. Okay, they might have done the homework, which you might not have the proper knowledge and in explaining to them. And take things slow. Take one step at a time. There's no rush. There's no gigi macam kena jawab. Okay, right, that because to them, even taking out a tooth is something that is considerably traumatic. So can I say that working as an oral and maxillofacial surgeon stressful? Yes, it is. And when I talk about stress, I would like to be honest to everyone that if you work too hard without looking after yourself, it would be very unhealthy. And that's probably something that happened to me a while back, that we run into burnout. And burnout is not being tired of working. Burnout is actually a psychological illness or disorder or even a disease that you are not only physically tired, you are mentally tired, you're fatigued, and nothing else matters in the world. And so stress management, you really can't focus it anymore. It's very, very important. And we know dentist is one of the professions with the highest suicidal rates, and still one of the highest suicidal rates among dentists. But it doesn't mean that you have to go through a lot of stress. You just need to know how to handle the stress. And everyone has a different way of handling stress, correct? So I guess before COVID and during my training days, I love to travel. I love good food. So you can see that on the left side, that's Alfie, my second born. And he's enjoying a corn dog. So if you love food, go for it. If you love sushi, go for it. If you love pizza, then I would recommend crust in 160 Mount Kiara. Or, it doesn't have to be expensive food. It just has to be good food that's good for the soul, right? Could be your mom's cooking. Of course, mom's cooking are always best. Okay, excuse me. Right, if you have a partner, if you have a good friend, if you have a best friend, go out with them. Take them for walks. That's me pushing my wife on the skateboard in what's that place called? The big park, Taman Botani, KL. And again, my kids, I'm not frowning because I'm stressful. It's just so tiring. But again, they come back. I come back from work, and the only thing that they're looking forward to is to play with their dad. And if you know how to play, then it's stress relieving. Go back to your hometown. If your hometown is in some kampung, but nowadays hometowns are all in the cities. But this is my dad's house in Kota Baru, Kelantan, which was designed by my late grandpa, which is a carpenter. So this house is just facing the river, inside the river, in fact. And yeah, do something that clears your mind. And finally, find somewhere, whether it's nature, waterfalls, rivers, or if you're into hiking or extreme sports, that's the way to go. Just make sure that it's something that you do as a routine. It's not something that you do when you really need to do it, stressful wise. All right, okay. And I think that's the end of it. So again, this is my Instagram account, not because I want more followers, but more followers are good, but because I started off this account first is to record my own surgical activities. Then it turned out to be an educational profile, and then it became something a lot more sharing kind of profile for the public. So I use this account when I explain things to my patients. I say, jaw surgery, this is jaw surgery. Or wisdom teeth, this is wisdom teeth. So social media is probably the in thing, but use social media wisely. Okay, because if you are doing social media, and a lot of dentists are, and you have pictures of patients, be professional. Always ask the consent, ask the permission that you're going to share this. And again, if you do this kind of thing, be professional. And the thing is, it's networking. And the thing that we're going to do in university before you start work, or you just starting work, is to know a lot of people, because those kind of people might be the one that will help pick you up one day. With that, I end my presentation. Again, it has nothing to do with the title, bridging medical and dental fields together. But being a surgeon, you have to have it's in the middle. Okay, are you hospital-based or are you a dentist? And that's the sweet part of it, because the sweet part of it is that you do both, and you get to see both, best of both worlds. All right, thank you very much.
All right, thank you so much, Dr. Kamil, for a very interesting insight into your life as an oral surgeon. All right, without any further ado, shall we jump right into the Q&A session, Doctor?
Yes,
All right,
sure. Let's go.
All right, we'll start with our first question. It's from my dear friend, C.H. Tang. Good afternoon, Dr. Kamil.
Good afternoon.
You mentioned that the Dean of UM sent you to Ireland for OMFS training. Does that mean you didn't apply for specialization through the KKM or HLP pathway? If so, could you talk a bit more about specializing via the UM or academic pathway, and if such a program still exists?
So again, no, it does not exist. It's not something. Training pathways can be in a lot of ways, right? So this one did not go through KKM because universities are under Education Ministry. Okay, not under HLP because it's under the Education Ministry as well. So it's a KPM scholarship, right? It's a trainee lecturer scholarship. Why did he send back there? Again, because of my background of graduating in Ireland, and at that time, a known qualification to be an OMFS is to have the FFD RCSI qualification or degree, basically. So, and then there was someone who was willing to take me on over there in Ireland to train me. So it takes a lot of networking and connections to send a trainee to a different country altogether to be trained. So so that's where I met my previous consultant, Prof. Dasid, who also trained another Malaysian before me, and also trained a few more other Malaysians before me. Unfortunately, he has retired. So again, there's no more available pathway in terms of fellowship through the Ireland program, unless something else comes up, which is, I would say, unlikely. But that's how it's done, and that's how it was done with our pioneer surgeons, the likes of Prof. Rani, Prof. Zaina, and those who in the early days went to the UK. So they worked in the hospital setting. They gained a lot of training, how many years in training, and then they sat for the fellowship exam. So it's something similar to that. Only that nowadays, because there's a lot of master's program available worldwide, and the proper UK training pathway is to do a double degree, medicine and dentistry, and they go into internship, basic surgical training, higher surgical training, and only becoming a surgeon after probably when you're 40 years old is too long to supply the nation's demand. So yeah. Currently with KKM, I guess the pathway is again similar. You have to have a post in the oral surgery department in the hospital before you can apply. Of course, universities will open the application to anyone, really, as long as you fulfill the requirements. But to be under KKM, HLP, and so on, you cannot quit the government sector. Once you quit and become a private practitioner, then the whole thing is different. I hope that answers. Should we move on to the next question?
All right, for the next question, Doctor, an anonymous attendee asked this question. He said that, hello, Dr. Kamil. Since most oral and maxillofacial surgeons' procedures are quite extensive, have you or any of your colleagues experienced intraoperative or post-operative death, as in patient dying during or after surgery, How should we deal with the situation if this unfortunately happens?
Okay. So, fortunately, intraoperative, none at the moment, although I do know some of my colleagues, Prof. Firdaus and Prof. Zainab, have had encountered one case. As myself, intraoperatively, I am very fortunate not to have any. Post-operatively, yes, and that was a time when I was training in Dublin, and I was the on-call officer for the case. A patient who had a cancer surgery done with a flap, something similar to what I shared. 5 days after surgery, patient also has a tracheostomy, which is a breathing tube through the throat. And I was on call the night before, patient was fine. I left, saying bye-bye. Patient said, bye doctor, good night. And then in the morning, I was preparing for work. I was in the shower for 5 minutes. I got 7 missed calls from the ward. And just to know that my senior registrar called me and just asking me, where the hell am I? So I said, I just came out of the shower and said the patient is bleeding to death. So yeah, it's shocking because patient, you're at home, patient is in the hospital. There's no way that when you arrive, the patient will be alive unless a miracle happens. Very traumatic, indeed, very traumatic. Was it expected? No, it wasn't. I wasn't expecting anything at all because patient was doing really well, 5 days post surgery, no issues at all. But these things happen, I guess, and that's where cancer surgery does not have a good place in my heart because of past traumatic experiences. But then again, you have to sometimes go through it. Yeah. So if it does happen, how do you deal with it? Again, is it your fault or is it who's? I mean, it's hard to show fingers whose fault is it. So there's no use of saying who's wrong, who's right. I guess you just have to deal it as it goes. But normally what happens is that at the hospital, there will be a mortality and morbidity meeting, and where there will be a group of panelists that will be interviewing what happens, how did it happen, and so on. So, but I guess because I was a junior doctor there, so I wasn't called in. My seniors and my consultant was called to answer that. That's a normal procedure for any kind of death that happens in the hospital.
All right, doctor. We are very sorry to hear that.
It's okay.
Shall we proceed to question number 3?
Yeah.
All right, sure. It's from an anonymous attendee. The question is, what is the overall awareness among the patients about surgeries like this? What's their perception like? Do they think it is important as we think it is as a dentist or surgeon?
What kind of surgery is this?
I think they
Can the person be a bit specific? It's okay, we'll get back to that. Whoever sent that message, can you be a bit more specific what kind of surgeries? Okay, whether it's jaw surgery or the cancer surgery. I think that's the main 2 surgeries I was talking about.
Right, then we will skip the question 4 first. What happens if a surgery actually leads to a worse prognosis or result? For example, patient think he or she looks worse than, or he or she looks worse or other complications.
Oh yeah, I mean that happens every time, isn't it? That's where your consent comes in, and that's where your discussion with the patient to come up with an informed decision making before you lift the blade to do surgery. So in jaw surgery, patient's faces change, right? So I have to let the patient know, look, if you cover your face with a mask like we do nowadays with COVID, you won't see any difference. But once that mask is open, you'll be a totally different person. You'll have to make a new IC photo, passport photo, and so on. Even your families or relatives who you haven't seen in a long time might not recognize you. And if it changes for the good, then that's great. But sometimes it does not. And jaw surgery does come with changes in the soft tissues, especially the nose if you do an upper jaw, the chin if you do a lower jaw, and so on. And to most of my patients, what I tell them is that, look, I'm going to put your jaws in the best correct position that I can, but it's going to change your face. And most of the time it changes your face to a more harmonious relationship as compared to what you have at the moment. But there might be things that you might not like, and I cannot address that straight away. So you tell them, so this might happen, but there are ways of managing them. So if you don't like it, then you should not be going through the whole surgery straight away. So it's good to have an example of photos of cases they can share with the patient of what has happened. Because some patients said, oh, you're going to do my job, my nose is going to get bigger. I don't want that. So, okay, fine. Then let's not do the surgery because it's not life-threatening at all. So that's how I go on about it, really. Okay, we go on to the next.
Thank you, doctor. So moving on to the next question. It is asked by an anonymous attendee as well. Are there many opportunities for a dentist to go into the field of OMFS, especially in Malaysia? And how is the demand like?
I think I'm not the right person to actually answer this. But there will always be opportunities. Whether there is a lot or little, it depends. Right? But looking in the OMFS in Malaysia setting, there's so many universities that will be offering OMFS postgraduate training. The likes of will take it every year. USM, UKM probably as well. But there are also like universities such as UIA and also UITM coming up. So these are the universities that you would also want to look into when you apply for OMFS. But like I said, to be able to be called or even accepted by the interview, there's a bit of homework to do. Get your membership exams, do your basic medical sciences exam, do your hospital postings, and so on. Just get a lot of experience. Don't expect to work for 2 years and then getting into a program. It's very unlikely. Okay.
Okay, so we'll move on to question 6 by Svini Nahendran. Good morning, Dr. Kamil. Thank you for a wonderful talk. I am Dr. Tas from Orthognathic Naval Base. A few weeks ago, I encountered a patient with fear-induced seizure while I started doing my extraction. Since it was just for a few seconds, I deferred my treatment immediately and called the medical team to assist me. My question is, what can we as a dentist do besides history taking to find out for such medical emergencies during our treatment procedure?
Right, so hi, Dr. Tas. So you had a patient with seizure during a dental extraction and treated, deferred treatment immediately, called the medical team. So the question is, besides doing history taking, what can we do? There's nothing much really that you can do, but the history taking part depends. How do you take the history? So when you know someone who has a tendency for seizures or epileptic attack, first you would want to ask is, are they on medications? What medications are they on? Are they on any follow-up with any doctors, any neuromedicine doctors? And how prone are they to get seizures during the week or during the day? So if someone who has seizures on a daily basis, then there's a high risk of them developing a seizure during the treatment. Okay, so what should have been done is that if that was the case, then the patient should have been referred back to the treating physician and be asked whether this patient needs some kind of change in medications or management at all, and whether the patient is compliant to the medications, because sometimes the patient factor as well, they're not compliant, they don't eat meds. Once you have feedback from the treating physician, whether it's stating the patient, seizure is good, it's controllable, then yeah, if you feel you can manage it under your own dental clinic circumstances, then manage it, as long as you have a good medical backup. Or if you feel that, no, I can't do it, I'm not working hospital-based, where this patient would likely need some kind of assistance in any kind of emergencies, then refer to a hospital-based dentist to carry out the procedure. But again, when history taking is the only thing, it's probably not the only thing. Of course, you have to know your medical emergencies, how to treat a seizure, how to keep the patient safe during a seizure attack, and so on. But besides that, I am confident enough to say that even most private clinics don't have an emergency trolley with the proper medications as well. Okay. Can we take probably 2 more questions?
All right, doctor, moving on to the next question. Okay. Hi, Dr. Kamil Hassan. Thank you for the wonderful sharing session. Any opinions or suggestions for dentists with musculoskeletal disorder, in brackets, chronic inflammatory disease, to specialize in OMFS?
Okay. With musculoskeletal disorder, chronic inflammatory disease, to specialize in OMFS. I guess it depends whether how bad is this disorder, disease is affecting your daily life. It is quite a demanding job, but depends on what you do. If you do local procedures, that is fine. It's like on the dental chair. But again, it's hard for me to say because I don't know how bad the condition is. But if I'm saying that this is hard to comment on. But if the condition is severe or even moderate and it interferes with your daily activities, then before you even become an OMFS surgeon, the training itself is quite demanding and takes long hours, long operating hours in the operating theaters, and it's a stressful, demanding job as well. So again, it depends on how bad the disorder is. I honestly haven't met anyone with a known musculoskeletal disorder, but I myself have scoliosis. So my vertebra backbone is an S shape. And do I get back pain? Yeah, I do get back pain. So what do I do? And this is based on my orthopedic friends' advice, is to strengthen my core because my back is not straight, so I have muscular imbalance. But besides that, I don't know what musculoskeletal disorders and how bad is it. But it depends on the severity. Otherwise, it should not be. I mean, if it's not bad, it should be a problem as long as you can manage it.
All right. So just to go to clarify from the third question from earlier, I'll repeat the question, yeah?
Yeah.
So what is the overall awareness among the patients about surgeries like this? And as for that, they meant jaw surgeries.
Okay. Awareness. Not much in this part of the world, because Asian population, our population, we tend to have a skeletal tree pattern. Our midface is a bit flat, our jaw is a bit bigger. For Jordan, like Jordan, he has a big jaw. I have a weak jaw. Okay, I would love to have jaw surgery done myself, but probably not. But the awareness is not. It's not as what we want it to be. Some people just accept the way that they are, and that's fine as long as they're functioning well. But often it's brushed off to the side. And why would you want to have surgery done if you are functioning perfectly? You live the life 20 years, 30 years, your jaw is like that, but you can still eat, drink, talk. So again, it could be cultural, religious as well. But the main aspect of doing corrective jaw surgery is to correct the jaws and make sure that you have optimal function. And that means when you have optimal function, you are likely to have a better quality of life. That's basically it. So I don't have numbers to know what the awareness is, but I don't think it's that high at all.
All right. So due to time constraint, we won't be accepting any more questions.
We do one more. We do one more, Jordan. Just do one
All
more.
right. All right, sure.
Okay.
Okay. Okay, here's the last one from an anonymous attendee. How to overcome the feeling of not getting a satisfactory result of the treatment done, although the patient is actually satisfied?
That's very hard. How do I overcome? First of all, I would feel unsatisfied. Second of all, I would feel upset. And the third, I'll hide in my room and then I just cry. No, I'm kidding. I wouldn't. But how do I overcome this feeling? It's that, why is the patient happy? There must be a reason why the patient is happy, right? And why am I not happy? So I come down to what am I actually feeling? So I guess I would always like to offer the patient, look, I can do something else if you want to. But if the patient says no, then the patient says no, and then you move on. But how do you overcome it is by actually learning what you could have done instead and try to improve for the next patient when the patient comes. Okay?
I think this will be a very short question. It's from Dr. Tas. The second question is,
okay.
for instance, if the patient has just cured from dengue, is it necessary for us to check on the patient's full blood count before we start on any surgeries or extractions?
Of course, with dengue, your platelet counts can reduce. So you don't want to treat someone with low platelet because then they have bleeding tendencies, and if it's a very low, it can be a bleeding emergency as well. So it's not often that people actually do a full blood count after dengue, but it's good to have it. Or what you can do is that if the patient was discharged from the hospital, I'm sure they did some blood tests and see what the blood tests show. But it depends again on the severity of the dengue. Okay? Awesome.
Unfortunately, due to time constraint, we are unable to address all the questions. However, the rest of the questions will be attended by Dr. Kamil and will be posted on our Instagram page, PIDC Virtual Circle. So do follow us on Instagram. And again, I'll repeat our Instagram page, PIDC Virtual Circle. We create interesting contents, host webinars, and organize activities regularly. That's all from us. Have a beautiful weekend.